Good morning. My name is Maggie Westby, and I will be speaking about virtual wards for people with frailty. Is there evidence to think anew? I'm grateful to my colleagues from the Applied Research Collaboration West. So some background, frailty and the NHS. So people with severe frailty have a minor event, such as UTI, which leads to a crisis. For example, delirium, sudden immobility, severe falls, which leads to acute hospital admissions, poor outcomes, and dependency, from which patients do not fully recover. This is illustrated in this slide here. And alongside that, prevalence of severe frailty is increasing, which is leading to a crisis for health services. So we asked the question, are frailty virtual wards the solution? And an ArcWest project started in 2021 with the following aims: to identify the different models in operation in the UK, to understand how and why virtual wards may or may not work within their specific context. And we are not looking at effectiveness. And we went on to conduct a realist review. Meanwhile, NHS England had produced guidance on virtual wards for people already experiencing a frailty crisis, and this became one of the contexts for our review. So starting with frailty virtual wards, our definition at the outset, which is from the literature, was that care is provided to the patient in their own home, and a multidisciplinary team makes decisions and plans care remotely from the patient. The MDT provides oversight of patient care. And when we say virtual, as in virtual ward, we mean that the MDTs plan each patient's care remotely. And we're not talking about remote patient monitoring, which was rarely found for frailty virtual wards. So a rapid realist review, very briefly, it is a theory-led review of diverse evidence. We identified 28 documents, mainly from the UK, and they went back as far as 2012. There was collaboration throughout with patients, caregivers, and clinicians, and our output was 12 context mechanism outcome configurations under 3 themes. So there were 2 main types of frailty virtual ward in the UK. Longer term ones that were more than 21 days. Patients had a high risk of a frailty crisis. They were given proactive care to prevent that crisis and were discharged when frailty was stable. In the short term virtual wards, 1 to 21 days, patients were already in a frailty crisis. They were given reactive acute care and they were discharged probably when the crisis was resolved. And as far as our 3 themes for how frailty virtual wards can work well, there were some building blocks essential for the virtual ward operation. And they were common standards agreements, information sharing, appropriate MDT composition, MDT meetings, otherwise known as virtual ward rounds, and a virtual ward coordinator. And our second theme was about how virtual wards deliver frailty management. And then we had a third theme that was about patient and caregiver involvement and empowerment. There were a number of mechanisms we identified, which I'll briefly run through. So professionals motivated to work together, team of teams, trust in shared goals, the buy-in of professionals, good communication, and patients feeling safe, supported and empowered, and caregivers as partners in care. And also emerging from this realist review were some other things, which included a whole system approach, the need for that, and proactive care to reduce crises for the long-term sustainability of virtual wards for frailty. So moving on to talk about that. So in terms of proactive care, breaking the vicious circle. So here's this diagram again, referring to that. So people with severe frailty, a trigger sends them into a crisis. They have poor outcomes. They're treated, but they don't fully recover, which puts them more at risk of a further crisis. And it just goes round and round and round again. And the result of that is likely to be risk of readmission to virtual wards or to hospital, on top of increasing frailty prevalence, which then leads to a potential overload of virtual wards, which is clearly not sustainable. What can we do about that? Well, we need to break the circle, and the way to break it is proactive care. So how is proactive care delivered in virtual wards? So both of these virtual ward models aim to prevent hospital admission, and they either do it by preventing the crisis in the first place or treating the crisis out of hospital. Proactive treatment can actually take 6 months, so it's clearly not possible for short-term wards. So there is a need for post-discharge proactive care. But the evidence is showing that discharge to the GP can be uncoordinated and unpredictable, especially from short-term virtual wards. And as well, virtual wards are not 24/7. And the evidence is identifying that caregivers may not cope with frailty crises, particularly if they happen at night, and leading to caregiver burnout, hospital admission for the patient. Now, temporary fix might be virtual wards being 24/7 or considering night sitters, but it is something that needs dealing with. And virtual wards should be integrated into frailty management and not standing alone. And here's an example from one of the papers that we looked at. And it's the kind of a whole frailty pathway with everything in it, and virtual wards somewhere in the middle. But I just want to say that, it's one part. So moving on to looking at delivering proactive care in a whole system approach. So as we should be taking a whole system approach to virtual wards, including patient selection and discharge. But for sustainability, we aim to prevent high-risk patients reaching a frailty crisis, but we still need acute care virtual wards. So we should be identifying in primary care patients with severe frailty who are at high risk or wobbling, and offer them proactive care, either in the virtual ward itself or under GP schemes, which we might call pre-wards. And we should consider having both short-term reactive and longer-term proactive virtual wards, or treating the high-risk group and those who are in crisis in the same virtual wards with the RAG rating and the same staff. So, and that as well as that, ensuring effective discharge and transition from a virtual ward. So proactive care should be started or continued by the GP to prevent further crisis and to stabilise frailty, for which we need good communication, caregiver involvement, and systems in place. So for further information is our article in Age and Ageing, and we also produced a policy briefing, which is well worth a read, and press releases and so on, and a blog for the BGS, which is a slightly different take. And thank you very much.